I'm Catherine Phillips. I'm standing here today with the great privilege of being the association's 75th president of HFMA. When I started my NHS career 33 years ago, I never imagined that I would become a CFO, let alone be standing here on this stage as your president. I feel truly honoured to take on this role, and thank you for entrusting me with this responsibility. If there's one thing I've learned in over 3 decades of working in NHS finance, it's that the challenges never get any easier. And I've carefully chosen my theme to help us all achieve what's required of us over the coming year and beyond. My theme for this year is embracing the future.
That was Catherine Phillips, HFMA President for 2025-26, as she unveiled her theme for the year, Embracing the Future, at the HFMA Annual Conference. Welcome to HFMA Talk, the podcast for NHS Finance. I'm Alex Hunt, and today we're bringing you the second episode in a 3-part mini-series covering highlights from our recent annual conference. Day 2 of the event was centred around Catherine's theme. It gave healthcare finance leaders the chance to discuss the 3 main shifts outlined in the government's 10-year health plan and what this means for the healthcare finance function and wider NHS. The plan was published in July 2025 and sets out a decade-long vision for how health services in England need to change to remain sustainable, effective and accessible. The plan focuses on 3 major shifts: from hospital-based care to community-based care, from treating sickness to preventing ill health, from analogue to digital. Throughout the day, I spoke to speakers and delegates about the 3 shifts and what these mean. First, I spoke to Hannah Whitty, Regional Director of Finance for NHS England, London Region, about the plan's ambition to move more care out of hospitals and closer to people's homes. The panel that you were just talking on was all about kind of the move from hospital to community. What does that shift mean to you?
I think in London this is care closer to home that meets the needs of the population that we are there to care for. So we've got to understand the needs at a very hyper-local level. But in London, the way that we're looking at it as well is because we have quite a transient population, it does move in and out, we want to have a core to the model that we are providing that is recognisable to all Londoners, regardless of which neighbourhood health service they walk into. So it really is that care closer to home that meets the needs of a population and then hopefully results in fewer people turning up in our really, really pressured secondary care services.
What are you currently working on to help implement this change?
So at the moment, we have a target operating model. We're in the process of selecting integrators, which will be the people who are responsible for providing the platforms and the infrastructure. We are awaiting detail from the budget announcement around private funding that will potentially be available, but we're doing a lot of work with our partners, so the GLA and also London councils, around one public estate, and what our void space looks like, what our building and infrastructure looks like, and how we can make the transition into co-located, digitally enabled services. We've got a long way to go on all of that.
And on top of hospital to community, what other kind of focuses of the 10-year plan do you think are kind of important that the community as a whole focus on right now?
Yeah, so, I mean, in neighbourhood health, I think the lovely thing about it is, although it is the hospital to community shift, we are really looking to digitally enable that care and to empower patients to access their care records and to interact with health professionals via the app. So we're looking at a really digitally enabled version of neighbourhood health. And if we get this right, and if we get public health data at the core of this, that wraparound and care, I think, will be doing more on the preventative scale rather than waiting for illnesses to arise and for people to move into crisis situations with their mental health and then having to treat them further down the pathway.
There was a lot of talk about kind of mental health and then that split between mental and physical health and how that has how that has previously been separated. Could you talk a little bit similar to how you did on the panel then about how you see that changing?
Yeah, absolutely. So I think, we receive budgets for mental health and we receive budgets for physical health at the moment in England. It's interesting to hear from Heleth where they think about it very, very differently. And I think that's more of what we need to move to. So the ideal for this would be a capitated budget. So you empower health and care professionals, and it's the care part of this is so vital in terms of adult and children's social care, domiciliary care, to get the right support wrapped around people. But if we can, we need to go on a journey around this. We need to change the financial framework. But if we get this right with the integrated health organisations in terms of whole population budgets, then I think it will start to remove some of the silos and the way that we treat people in silos currently, which is still, I think, a very real issue for us.
What do you want to see from finance leaders, your fellow peers in the annual conference today? What do you want to see from them in terms of support in implementing?
Yeah, I think the three key panel sessions today are all around those shifts. So I think there's a little bit of awareness of what's going on and taking that back into organisations and challenging the status quo around how we do this. We have an awful lot of work to do on financial incentives and the framework, and we will be looking for people to actively get involved to help NHS England in the design of some of this. So we will be looking for volunteers to help us in how we get the right financial frameworks and incentives in place.
From treating sickness to preventing ill health, the second shift is all about prevention. Rather than focusing primarily on treating illness once it occurs, the plan emphasises keeping people well for longer. This includes earlier intervention, better management of risk factors, and addressing wider determinants of health, such as deprivation and inequality. For finance teams, it highlights the long-term challenge of investing in prevention now to reduce demand and cost pressures in the future. I spoke to Dr. Diane Aday, Director of the National Healthcare Inequalities Improvement Programme at NHS England, who shared how the NHS is embedding prevention, early intervention, and population health approaches to reduce inequalities and improve outcomes. You've been talking about from sickness to prevention today. What does that shift mean for the NHS and why is it so important right now?
It's very important because we cannot treat our way out of the crisis that we have. If we do not move the dial to the left, if we do not focus on prevention, we're going to keep having a health service in crisis. That's the bottom line. That doesn't do anything for the health of the population. We're also talking about the economy. If we have people who are not well, they cannot work, they cannot input into the economy. So there's the economic reason, there's the health reason, there's the moral reason. We want healthy people to contribute to the economy. We want them to contribute, do their best, input into the society they are in, be part of the society. We don't have a choice. We've got to move it to the left.
So if we get this prevention agenda right in the next 10 years, what difference will that make for patients and the wider NHS?
If we get the prevention agenda right, the first thing that I want to say is 10 years. Okay, so prevention takes a long time. And that's something that a lot of people don't like to think about. So we can get some small wins. Okay? We can get some wins, definitely. But prevention takes a long time. And it's important we have that mindset going into it. So that's the first point that I'd make. What will it mean in the long term, in 10 years for patients? I think we will be able to decrease the pressure on the health service than we currently have. It will bring the pressure down, bring the dial down. If you have healthy people who are taking up their vaccines as they should, etc., we wouldn't have so much of a crisis at winter. What you shouldn't forget is that we tend to think of the frailty of old age. But those people that we are thinking are going to be occupying the winter beds, they are in their 40s and 50s now. So if we do something about that, by the time they hit 60, they will not be as frail as people would be now. So there's the short-term impact, and then there's the longer-term impact. Short term, we are thinking of urgent and emergency care, waiting lists. We want to bring those down. We want to bring the cancer weights down, the diagnostics down, the wait for whatever it is. We want to bring that down. Let's shift it to the left, and that would help decrease the pressure.
Why would you encourage NHS staff members, healthcare finance members to attend events like this to learn about health inequalities?
Reducing health inequalities is everyone's business. It's my job as Director of Healthcare Inequalities, yes, but it's everybody's job to make sure that we all have equitable access. When they come into hospital, they have an excellent experience. Because if they have a poor experience, they won't come and they'll come late. And then they'll require a lot more resources. And they have optimal outcomes. That's why the health service is there. We want people to have optimal outcomes. If the people who are at the point of care don't realize that they have a role in ensuring when people come, they're comfortable, in ensuring when people come, they get the right tests, in ensuring when people come, they get the simple 2-minute interaction to talk to them about their smoking status. If we don't do that and we don't encourage the staff to do that and get equipped and confident to do that, we're failing millions of people who make contact with the health service every day. Every day. I don't come in contact with patients every day, but the nurse does. They weigh them when they come into hospital. They ask about their smoking status. What do they do with that information? What do they do with that opportunity to make a difference? It's important people should know. What would I do about it? I think it's not just about coming to specific events like this. These are important, but it's also important you train people where they are. It's also important within the hospital. The receptionist, for example, knows where to direct people who are smoking, and there's a hospital service and says, actually, you could go here. Make every contact count, is what we say.
It seems to me that from sickness to prevention is kind of one element, and you're speaking about health inequalities within that kind of framework today. But it seems to me that it touches every aspect of the 10-year plan. From analog to digital, there's a lot we can do with data. And then again, from hospital to community, and you spoke a lot about community today.
Yes, so I was asked to talk about prevention, and so I focused on prevention. But yeah, I have a big digital inequalities program. It's not everybody who's digitally literate. Yeah. And we have to make sure, for example, that if we're going digital with our services, if I don't have data, I cannot access it. It's important people feel comfortable with digital to be able to engage with a digital service. It's important that we educate people, that people have that health literacy, that people are empowered to make choices, to make healthy choices of their own. So it bleeds through everything. I said it's everyone's business. It's the person who's making the decision about finance. It's your business. It's about the model of care. It's about the trust chief executive thinking about it and saying, how do I harness the estates, for example, to support the community, to get them engaged, to get them to realize that coming into the hospital, for example, is not necessarily a negative thing. You've got buildings that are not optimally being used. Is there something that you could do to engage the community, to find, do something in there, bring in the community, let them own it, be part of it? That's all very important.
From analog to digital, the third shift focuses on modernising the NHS through digital technology, setting out ambitions to expand the use of tools like the NHS app, shared patient records, remote monitoring, and artificial intelligence. The goal is to make it easier for patients to access services, improve information sharing across the system, and reduce the administrative burden on staff. I spoke to Alex Crossley, Director for Transformation Strategy, Finance and Delivery at NHS England, who outlined the NHS's major digital priorities and what they mean for finance, delivery and transformation. Your whole session today was around the shift from analogue to digital. What does that mean for the NHS, especially over the next 10 years?
So fundamentally, analogue to digital is about delivering better services to patients at lower cost and improving our productivity. We need to adopt, we need to start delivering like the private sector, like any other industry has done, and provide patients with the services that they expect in a modern digital way. That gives us some incredible opportunities to give them better services while stripping out some of the costs that we've got today. There are things you can deliver digitally that we just can't do in an analog way.
Yeah. If you had to boil it down to just like one change that the NHS could make right now to make a massive impact, what do you think it would be?
I'm not sure it counts as one thing.
Yep.
But my simple line would be we need to move to a model that is digital by default. Every management decision we make, we need to be starting from a principle that we engage digitally where we can, whether that is transactional services like booking an appointment, or whether it's clinical engagement on pathways like MSK.
And obviously at events like this, you get to speak to NHS leaders and peers. What do you think they could be doing today to make sure that they're ready for the kind of digital priorities set out by the 10-year plan?
So I think all of us as professionals in the NHS have a responsibility to think about our own skill sets and how we're going to work in a digital world. The technologies that we're working with, the innovations available to us are moving really, really quickly. We need to update ourselves. We need to reflect on our own ways of working, think about how we can digitise, how we can automate, how we can get more value out of the resource we've got today.
You were kind of speaking in your session about how we kind of really need to scrutinise the technologies that we're implementing and obviously see them as like profit systems, not just straight up cost. And I was kind of interested to know, where do you see the line between, especially maybe with something like AI, jumping into a technology like that because you don't want to miss out, but also it is such a new technology and could cost millions and millions and millions of pounds and might not even be the right thing. Where is the line between kind of getting that right?
And there's no right answer, right? So the single thing we can do today is optimize what we've already got. That's the quickest, easiest way to get productivity gains out. But yes, you're absolutely right. We have to be embracing those technologies. We have to be working with them. I struggle to see a world in which we as the NHS should be investing, building our own large language models, right? It's an incredibly complex science. It costs an absolute fortune. I don't think we're going to get involved there. But I do think it is right for us to take managed risks about co-developing some products that we are going to need for the future. And there are some great examples of that where individual providers are already working with technology firms to design products that are right for the NHS or to pilot them to get the evidence that they're safe so that we can roll them out. I think that is totally legitimate. There are really exciting opportunities ranging from automating our finance systems all the way through to mental health.
During the breaks, I had a chance to speak to delegates about the 10-year health plan, what they thought the NHS finance community should focus on, and the support they need from leaders to make these shifts a reality.
What would be helpful from my perspective is understanding where it's gone well and how they've managed to make it happen. Mm-hmm. I've talked to people who have worked in organisations that are truly integrated from end to end, particularly the Welsh, like those from the Welsh system. And it's hard, it's really difficult, and it's not as easy just to make things happen. So it can't just be about organisations coming together. So when things work, how's it working? And how that we can start trying to identify the things that have the biggest impact so that we can focus our capacity on those. And I think that would be the bit from my perspective that would be most useful.
Brilliant, thank you very much. And then obviously we're here at the annual conference today. What do you think we need from the healthcare finance community to help implement these changes?
So I think it's twofold. So I quite liked Catherine's speech at the very beginning around looking after ourselves. So I'm really pleased to see that HFMA are going to have more resources around it. And I think it is more, looking after yourself and wellness is more than just turning up to a colouring session. It is, around things that make you truly resilient and about your balance in life and the things that you do outside of work as well as what we do in work, and opportunities to build networks and do things face to face. So the more HFMA can do things face to face in local areas and make it financially accessible, I think will be really, really helpful. And I then think the second thing then is, my first is the true cases where things have worked really well.
Yeah.
The NHS is huge. We have got best practice in many locations. How do if we could all just adopt 10% of the things that have gone well elsewhere, then we would make a massive financial difference. But it's knowing where they are and how to then adopt those and take them forward. And we do a little bit of that conference, like local conferences, but it's expanding on that.
Oh, I think it probably goes to the session, the first session we just heard about mental health. Having a son, an 8-year-old son, is a definite sort of brings into focus the younger population and mental health sector, learning disabilities, autism. I think some of the things that were outlined in that session in terms of the what's going on in London, so I'm at King's College Hospital, London, what's going on in London, look really like they're going to be a positive step in terms of we can do it at neighbourhood, at community level. And I think even as Hannah was saying, I mean, that supports all three objectives of the plan, really. Community and digital and from treatment to prevention. So, yeah, I think that's a good start. It is a tough one. I mean, like the conference today or over this week, it's like a good example to network with peers, find those examples of good practice, because we're all working on the same thing, right? So there must be something that we can all do together as a community to share that good practice. I'm sure that's what Catherine was saying in her pitch this morning. Yeah, I think it's that, and probably it's also a phrase we've been using: unrelenting honesty in the numbers. What we're doing, like we have to be honest about where we are.
Yeah,
we're in a challenging position. Keeping that honesty, finance have a job to make sure we bring that honesty, I think. And try and take the organisation with us on that honesty, I guess, as well. That's the point, isn't it? But yeah.
I think one of the biggest areas for me personally is the move to digital and the vast amount of data we have about who's buying what at what prices and what's being used, the trends we're seeing in the suppliers, is using that to make the decisions better. And if we can in the future, when we've got the 10-year plan, we start linking what people are buying to what patient outcomes are and what's produced the most value, not just in terms of cost, but in terms of cost to patient, total patient cost to treat them fully. I think that's my biggest focus personally. So the move to digital, there's a lot of good talk and we need to make good on in terms of sharing data better and getting it around the whole community better. And people are trying to do it, but if we can get the good data into the right place with people who can use it well to make the right decisions, we can do things so much better as a community. So that's one big focus for me. So data in one place we can all use.
What comes across for me from some of the sessions we've heard this morning has been that collaboration, that working together, integration, collaboration. We've just had 3 individuals talk about care, shift left, care in the community, the challenges, and what's apparent is they're not going to overcome any of those challenges without some collaboration and integration with a number of stakeholders, be that local authority from kind of co-terminus working, be that with third sector, volunteers. So that's what come across from me. So from a 10-year plan is how do we break down some of the tribalism that we come across, where people become quite precious because some of our targets are still within a 12-month window and we need to be thinking longer than that within that kind of strategy of 10-year. And another focus for me this morning on what I've also heard is, what about a workforce strategy alongside some of that? Because some of our challenges in West Wales is we've had similar funding for mental health as what England have had, pro rata. But obviously our challenges around the workforce. So it'd been good to have seen a bit more on that workforce strategy alongside that 10-year strategy.
I think the main focus would probably be more on the care close to home element of that 10-year plan and more community-based services that are available to patients, because we're all in the business of improving patient healthcare and introducing world-class patient care systems. And I think another big part of that would be around AI and how we then sensibly deliver AI into the NHS and health services and community health as we progress forward.
What kind of support do you think is needed to kind of implement the changes from the 10-year plan?
Yeah, so I think the first one is realism around how much it's going to cost. and where the sources of funding are going to come from, and the phasing of that sources of fund, because sometimes we need investment up front to release elements of funding. And then I think the main support that we probably need is, again, linked to realism, is, we're finance leaders, not magicians. And there is a difference between a mathematical financial plan versus an actual financial plan.
Yeah.
And we probably just need to be a bit mindful of the reality and the tolls it takes on finance leaders within the NHS.
To cap off the day, Sarah Woolnough, Chief Executive of the King's Fund, discussed the practical steps needed to deliver a sustainable future vision for healthcare. I spoke to Sarah after her closing keynote. Today's sessions have all been about the 10-year plan. What do you think are the biggest challenges currently for the NHS out of that plan?
Yeah, well, the 10-year plan is very full and ambitious. I think one of the key challenges is dealing with the short-term service pressures alongside some of the longer-term transformation and the 3 shifts that the 10-year plan discusses. How can you hold both, and how can you bear down on some of the waiting lists at the same time as, for example, making really fast progress on analogue to digital?
Obviously, you mentioned that digital was kind of like one of the biggest places for innovation from the 10-year plan right now. Where do you think that innovation is within the kind of digital sector for the NHS?
I do see pockets of great innovation in lots of different places and ways when I'm out and about in the NHS. So one issue is scale. How can you scale from pilot to mainstreaming it across your system or your pathway of care? I do think there are very fast opportunities around some ambient voice technology, enabling back office tasks to be done very differently. I think there is a key point about making this feel easy, seamless, understandable to people and patients. So if you think about how people interact with services, how is that digitised? How are we, thinking about people's journey, the classic customer journey, rather than just what suits the system?
Obviously, you're in a room with NHS finance leaders. You are one yourself. What's that kind of one piece of advice you would give people to kind of help support, implement these changes?
I think it is invest in people and leadership and capacity and capability. This point I made, it's ultimately people rather than plans that deliver change. And great workplaces, strong teams, a sense of coherence over what teams are trying to achieve is absolutely fundamental to actually drive change and deliver change. So I think it would be quite a people-focused message. I think maybe a secondary message is, look, we all know the context is challenging. So to remain hopeful and, there's lots of consensus about the change we want to see for the long term, even if the short term feels really hard, sort of backing yourself to head in a direction.
And just one final question, if you don't mind. In terms of kind of like the short-term goals, 2026, what do you think are the kind of main priorities for finance staff right now?
Yeah. Well, I think the government's priority is clear, and it's bearing down on waiting times and balancing books and driving productivity. So I think clearly finance directors have to hold that pretty strong. But I think there is a genuine opportunity to start rewiring the system in aid of the shifts. So, for example, I'm really interested in starting to move towards community neighbourhood health and the financial structure that will enable and support that.
Brilliant. Thank you very much for your time. I really appreciate that. Day 2 of the HFMA annual conference showcased the breadth of thinking and leadership required to make the NHS's 10-year plan a reality. From community-based care to prevention and digital transformation, it's clear that the next decade will demand collaboration, innovation, and bold decision-making from finance professionals across the NHS. In 2026, the HFMA annual conference is moving to Birmingham. We'll be delivering an enhanced programme and new opportunities whilst continuing to provide the outstanding conference experience that you value, and at a reduced cost for our NHS finance community. Be among the first to secure your place at the 2026 event in its new location and be part of our biggest and best conference and exhibition of the year. You can get your tickets by following the link in the show notes. Join us next time as I speak to Steve Brown, editor of the Healthcare Finance magazine, to discuss our learnings from day 3 of the conference, which focused on the priorities for the NHS in 2026. Thanks for listening, and don't forget to subscribe so you never miss an episode. If you enjoyed the show, we'd love for you to leave a 5-star rating on your favourite podcast platform. See you next time.